This is Danny Bogrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection web-based education series. Today's presentation is titled Obstructive Sleep Apnea and Oral Appliance Therapy, Connecting the Dental Dots, and will be delivered by Dr. Earl Bogrow. Dental offices are the #1 portal for identifying and screening patients for obstructive sleep apnea, a potentially life-threatening condition. It is, therefore, incumbent upon practitioners who embrace dental sleep medicine to master the techniques for articulating the importance of sleep to patients, health practitioners, and other referral sources. You will learn best practices for achieving this objective at this exciting and informative event. Earl K. Bogrow, D.D.S., is a Fellow of the Academy of General Dentistry, Diplomate of the American Board of Dental Sleep Medicine, Adjunct Clinical Assistant Professor in Prosthetics and Cariology, Restorative Sciences and Endodontics, and a dental sleep medicine consultant with the University of Michigan School of Dentistry. He has, since 1981, maintained a thriving private practice in Southfield, Michigan. Earl served with the State of Hawaii's Public Dental Health Department and is licensed with the Michigan and Hawaii State Boards of Dentistry. He assisted with the development of the dental sleep medicine program at the University of Michigan. Earl has spoken on dental sleep-related issues across the country, having been a Pathways Program invited speaker and student advisor from 2017 to 2019. As an attendee today, you will learn to build your practice, whether you treat or just screen your patients, recognize the important differences between medical and dental billing for reimbursement, select and present treatment options once someone is diagnosed with obstructive sleep apnea, compare compliance and effectiveness of CPAP to oral appliance therapy, collaborate with sleep physicians, choose from among the more than 100 appliances approved by the FDA for snoring and sleep apnea, minimize and avoid altogether treatment side effects such as TMJ, bite changes, teeth shifting, etc., and most important, save relationships and lives. You are invited and encouraged to submit your questions at any time using the question button on the provided menu. If Earl cannot get to your question during the webcast, he has promised to do so shortly following his presentation. Attendance at today's event entitles you to apply to receive 1 1/2 hours of PACE-approved continuing education credit. Shortly following Earl's presentation, you will receive information on how to apply to receive your CE. To be eligible, you will need to successfully complete a brief quiz, as well as note the following course number, which is BOG 022323. Again, that's BOG 022323. If you happen to be driving or could not get that code, we will be sending an email shortly following the presentation with a link to Earl's presentation, as well as that registration code and a link to receive your CE. And with that, it's my distinct pleasure to welcome to the Practice Perfection stage my good friend, Dr. Earl Bogrow. Take it away, Earl.
All right. Thank you, Danny. I appreciate you inviting me to give this presentation today. So for all of you who are interested in following this, the first thing is this whole presentation is about dental sleep medicine. It's not about sedation dentistry, which sometimes can be misleading when you hear dental sleep. It's about helping people who have obstructive sleep apnea. So I want to start the presentation just to let you know how I got involved with this before I get into my slide presentation. I've been a general dentist. I graduated from University of Michigan Dental School back in 1979. As Danny introduced me, I spent my first 2 years in practice in Hawaii, working for the public health department. Came back to Michigan, opened up a private practice, and have loved general dentistry. Loved dentistry. I had my own practice, private practice, for over 35 years. And then something interesting happened. And again, I have kind of the characteristic traits of many of my patients. And it started just from my wife complaining or noticing that I was snoring more. Not only was I snoring, but she also said sometimes she'd look over, I'd be stopping breathing. She said, sometimes I'd be making these little noises. I also, all of a sudden, was waking up 3-4 times a night where previously I used to sleep through the night very easily. And I'd be coming home from work more and more exhausted. So I'm thinking, hey, what's going on? So I finally mentioned this to my physician at a physical, and he said, let's give you a sleep test for potential sleep apnea. And I'm thinking, sleep apnea? Because I used to think that the only people that got sleep apnea were people who weighed 300 pounds with a 20-inch neck. I thought it was a fat old man disease. And then I started to read about this. So I had this test, and sure enough, I was diagnosed with mild to moderate sleep apnea. And I started to read about the correlation of sleep apnea and heart problems, sleep apnea and strokes, sleep apnea and diabetes, sleep apnea and fatigue, sleep apnea and AFib and other heart problems. And I said, hey, what do? I don't have any of these conditions at this point. Here's somebody, I weigh 170 pounds. I run marathons. I bike thousands of miles. I am not that 300-pound person that I used to think had sleep apnea. So what do you think they told me? At that point, 12 years ago, everybody got a CPAP. I got a CPAP. CPAP is just a machine. If you're not aware, it just stands for continuous positive air pressure, and it's a machine that blows air down your throat. I got it. I knew it helped me, but I didn't like it. You know, as statistically, most of my patients don't like it. And finally, I started to read in my dental journals about the use of the dental appliance. In lieu of that, I joined the American Academy of General Dentistry. I learned about dental appliance therapy. I had an appliance made for myself, and it was all for my own benefit at the time. And I had an appliance. I went back, had a follow-up sleep test, and sure enough, no more apnea, no more snoring, no more. Instead of waking up 4 times a night, I was now back to maybe once a night, and I didn't have that fatigue and that lull during the day anymore. So it worked so well for me. I jumped in with both feet, studied it extensively. I became a certified diplomate of the American Board of Dental Sleep Medicine back in 2012, incorporated into my dental practice, and to the point where I had another dentist take over my general dental practice. I loved general dentistry, but I found a niche that I really thought was important. I started to develop this to the point where I dedicated my whole practice to this, and that's where we are today. And now my whole practice is dedicated to sleep apnea. I'm at a point now, after some years of doing this, that I needed to. I am in the process of building a new office. You know, I guess the point is, be careful what you ask for. This has worked so successfully for me that I want to share this with you, and maybe entice some of these listeners to get more involved, or to do more sleep apnea practice, oral appliance therapy. So that's kind of my introduction of where I'm coming from. So
it's been fun watching your metamorphosis, if I might add, Earl, because I know when we started working together and became friends, this was just more or less a notion or a dream of yours. And I
just want to comment to the listeners, you know, I've known Danny Bogrow for some years now. He was kind of instrumental in me in helping me develop websites and some of my marketing ideas, and kind of help me concentrate on what I'm doing and building what I have. So I want to thank you, Danny, and asking me.
Well, I appreciate that. I do appreciate it sincerely. I wasn't fishing for a compliment. I just wanted to acknowledge that you've done it. It's been fun watching your development here, and the fun that you're having while you're helping so many people. So your passion is already self-evident, and just want to make sure that people understand that this isn't an overnight kind of a process, but you're glad you went through it, for sure.
Yeah, it's an overnight over 13 years. It's
yes.
Overnight. So let's get on with the presentation. So what are the objectives of this next hour of this presentation I want to give you? It's to introduce you to this field of dental sleep medicine and what dental sleep medicine, and it's a whole field of collaborating with dentists, with physicians. Obstructive sleep apnea is a medical diagnosis. As dentists, we cannot legally diagnose it, but we can work with physicians in getting the patients the best care. And one of the options is the dental option. So, if nothing else, I want you to be aware that as dentists, if the audience is full of dentists and dental staff, that it's incumbent upon us that even if you don't want to treat anybody with oral appliance therapy, at least to screen your patients and be able to give our patients the best care they can. And again, the oral systemic connection is so important that we need to know what we can do and what to look for. And that's hopefully by the end of this next hour, you're going to feel a little more comfortable with that. So if I can get my screen to work. Next slide. All right. So here we go. So if nothing else, these are the numbers on the screen, 40, 70, 80. What does this mean? Well, about 40% of the adult population snore. Of people who snore, about 70% of those people have clinical obstructive sleep apnea. Of those people, of the people who have sleep apnea, at least statistically, 80% of those people are undiagnosed. So what does that tell you? It tells us that there are millions of people walking around with these signs and symptoms of obstructive sleep apnea, whether it's just snoring. It usually starts with snoring, but it's not just snoring. It's snoring, and it's interrupting your sleep pattern. So you're going to learn a little bit about sleep, about the importance of sleep. You know, most people talk about health. They talk about diet and they talk about exercise, but that third component of health is good sleep. And if you don't get good sleep, any one of those three categories, whether it's diet, exercise, or sleep, can affect the other two. So being healthy is taking care of yourself. And as dentists, to see that 80% of people are still undiagnosed, what does that tell you? It tells us that we have incredible opportunity to help a lot of people. And if you're not screening for obstructive sleep apnea, it's not just affecting your bottom line. Look at some of the statistics of what people have who are untreated with obstructive sleep apnea, from anywhere from having complications just from a dental side, the healing of somebody who is impaired. Not everybody who's a bruxer has sleep apnea, but just about everybody who has sleep apnea is a bruxer. Not everybody has acid reflux, but most people who have sleep apnea do have acid reflux. There's kind of a pressure buildup, and the acid builds up and comes out. And so it not only does it have an impact on the patient's health, but it has an impact on our dentistry that we do. So the success of our dentistry could be affected by people having sleep apnea. So what does this mean? When I talk to patients, because all sleep apnea, all it is, you're going to find out, all it is a closure of your airway when you sleep. You can go 3 weeks without eating. You can go 3 days without drinking, but you can't go 3 minutes without breathing. And when you have sleep apnea, there's a closure of the airway, and it can affect you in so many different ways. So the importance of breathing. Again, this slide just to kind of reinforce that if your airway is closed for more than a few seconds, there's a release in our body of adrenaline and cortisol, which can cause so many other medical problems, and it interrupts your sleep stages. So there's so many factors involved with sleep apnea, and the biggest one is the impairment of breathing when you're sleeping. When you're awake, we breathe fine, but we go to sleep, everything changes. Our airway gets smaller. Our tissues in our throat kind of close down, and it affects our whole system. So let's start out. Just what is sleep and why is sleep important? And again, I kind of alluded to this, that along with diet and exercise, healthy sleep provides the essential foundation for everything we do in our health. And again, why do we need sleep? You know, it used to be the badge of courage. Oh, I only need 2-3 hours sleep. That's not true. Anybody can try to get along with less sleep, but there's no way that you can get by that you only need a certain amount of sleep. You really need at least 7 hours sleep. So if anybody in the audience is getting less than 7 hours sleep, we're in a sleep deprived world, I want you to know. I mean, right. I would say about 40%, I've looked at some statistics, about 40% of people get less than 6 hours sleep. over
And
60 million people are taking prescription sleeping pills to help them sleep.
And isn't it true that the harm from sleep deprivation is cumulative?
It's so cumulative. It definitely is cumulative. So just, if you're getting 5 hours sleep 6 days a week, that last day to just get 8 hours sleep is not gonna do it. I mean, just motor vehicle accidents. There are over 300,000 motor vehicle accidents per year that are caused by people, drowsy drivers, or people falling asleep at the wheel. So it's really a social epidemic as well. So let's talk a little bit about the stages of sleep. When we go to sleep, just in simple terms, we have periods of very light sleep, we have periods of very deep sleep, and we have periods of what's called REM sleep. And REM stands for rapid eye movement. And when we go to sleep, we just don't go from light sleep to deep sleep to REM sleep, but we actually cycle through these stages every night. The average person has approximate 90-minute cycles. The first 90 minutes of sleep, we get about 10 minutes of REM sleep. In the second 90 minutes of sleep, we get about 20 minutes of REM sleep. In the third 90 minutes of sleep, we get over 30 minutes of REM sleep. So the most important sleep for most people is in the 4th to the 7th and 8th hour sleep. And if you're only getting 4 or 5 hours, you're never getting that long-term sleep, that long-term REM. And REM sleep and deep sleep are so important because REM sleep is most important for feeling refreshed during the day. We do most of our dreaming in REM sleep. It is so important that if we're not getting it, that's what throws everything off. And when you have sleep apnea and your sleep is being interrupted, it throws off this whole cycle of the stages of sleep. And I can go into that and just talk a whole lecture on just the stages of sleep. But what is normal breathing, and how is the dental world related to breathing and that? Well, when we breathe, air passes through the nose, past the structures, and there's an opening in the back of the throat. We can either breathe through our nose, we can breathe through our mouth, and the space in the air goes down into our lungs and we breathe. But when we go to sleep at night, some people have a tendency, our tongues have a tendency to drop back. Our soft tissue has a tendency to drop back. Our neck muscles kind of relax and start to sag. And all of a sudden, that space that's wide open during the day gets smaller and smaller until one of two things happen. Either the tissues in the back of the throat will start to vibrate against each other, which is what snoring is, or the worst case yet, it'll even get to the point where the airway just collapses, closes. I always say when I talk to patients, it's like taking a garden hose and bending it. What happens? It's totally closed off. Nothing can go through. So when our airway gets blocked, as you can see in this picture, it's basically you're just holding your breath. It's just a collapsing of that whole structure in our throat. And that's typically where sleep apnea occurs, is in the back of the throat, right at the junction of the back of the tongue, the uvula, and our throat and our neck muscles. And when that tissue closes, and our brains have all these sensors, and when it senses we're not breathing for more than a few seconds, there's a release in our body of that adrenaline and cortisol, and it's almost like, I always say, it's like getting an espresso in the middle of the night, and it's like your body say, hey, wake up so you don't die, so you start to breathe again. And then a few minutes later, it dissipates out of your system, and then the next thing we know, the patient's snoring again, and then the airway closes again. So that continual cycle of the airway getting closed, closing off, and then reopening, and then doing it again and again and again, and then that throws off all those stages of sleep that I just mentioned. So there's certain words and certain definitions that as you get into dental sleep medicine, it's important. Well, we all know what snoring is, and it's just the partially obstructed breathing. There's the air is going through, but it's vibrating. It's at the back of the throat. But then there's obstructive sleep apnea, like I just showed you in the previous slide, where the tongue and the soft palate collapse and closes off the airway. And then there's something called when the physicians rate the severity of sleep apnea, are doing something called, they look at what's called an apneic episode where the airway's totally closed, or a hypopneic episode where there's a reduction, but there's still the release of the adrenaline and cortisol, and it's still affecting your system. Then there's, how do you test for sleep apnea? There's two ways. There's two ways to get tested for sleep apnea. One is called a polysomnogram, where a patient goes into a sleep lab and they put 20 electrodes all over your body, and they're measuring all the aspects of your breathing, of your heart, and it gives you a measurement. Today, more and more sleep testing is done with home sleep testing units that people can wear in their own beds. Is it as accurate as a polysomnogram? No, but just like many things in medicine, they're dictated by medical insurance. Medical insurance would much rather pay for a patient to have a home sleep test versus, which would cost a couple $100 for the insurance company, versus a polysomnogram, which is a several $1,000 test. But, and again, the home sleep testings are getting more and more accurate. So it's getting to the point, and I predict within the next few years, most people are just from their sleep, their apps on their phone, from their smartphones, are going to be able to give almost as accurate numbers as the polysomnogram. It's not quite there, but I think it's going in that direction. So then there's the term, the AHI, which is the apnea-hypopnea index, which is the number of times, in a simple terms, it's the number of times in an average hour of sleep that your airway shuts down for at least 10 seconds at a time with a concurrent drop in the oxygen level of your blood of at least 4%. So 0 to 5 times an hour is considered normal. 5 to 15 times an hour is considered mild apnea. 15 to 30 times is moderate, and over 30 times an hour is severe. Well, I want to tell you, first of all, I hate the term mild, moderate, or severe, because if somebody has sleep apnea, they have sleep apnea. And slowly but surely, it's going to catch up with them, and all the symptoms that I mentioned, just that I experienced and many other patients experience, will come to the surface. So it's not just...
Let me ask a clarification question on that, if I may.
Sure.
Do you mean to say that somebody with mild sleep apnea is not going to remain mild? That eventually it will increase in severity?
Here's what typically sleep apnea gets worse with age for two reasons. One, most people as they age gain a few pounds. Weight gain is one of the most highly contributing factors to sleep apnea. But I have many patients skinny as a beanpole. Some people just anatomically, genetically have a smaller airway. But the other thing that we cannot change as we age, as people get in their 50s and 60s and on, is our muscle tone and our tissue tone just kind of collapses a little more, sags a little more. We can't control that with age, but we can, so that is why it usually doesn't get better on its own. Some people can just lose weight. That's usually one of the first things we can do, just as a treatment, a non-medical treatment, is just to lose some weight and take care of yourself. There's another term which I don't think we even need to get into, which is where it's not quite an apneic episode or a hypopneic episode, but your airway is still becoming affected. But I think that's for another time. So what happens when you have sleep apnea? What's the thing? As I alluded to, you start to sleep, your airway gets compromised, it closes down, it reopens it, so it changes, it affects the stages of sleep, so you're not getting the normal stages, so it's all of a sudden you're not getting the deep sleep, you're not getting the REM sleep that you need. So the first thing that affects, every time you have one of these episodes where that adrenaline and cortisol is released in the body, it's almost like getting a jump start to the heart. It's like a little, that little jolt. And that's why there's direct correlation with heart problem, with AFib, because it sets off these cardiovascular complications, which then can affect other parts of your body. So it's kind of just a vicious circle of treatment and problems that one thing just kind of feeds on the other until you're not sleeping, you become sleep deprived, you just can't function well. You're not eating right, you're not exercising right, and it just keeps getting worse and worse, and that's why the health of people with constant sleep apnea just keeps going down. So, what are common signs and symptoms of sleep apnea? I mean, the first thing, it used to be thought snoring is a joke. Well, snoring can, like I said from the right beginning, 40% of the adult population snore. Of those people, 70% of those people are clinically sleep deprived and clinically have sleep apnea, which leads to excessive daytime sleepiness. Most people have sleep apnea. They one of the things they claim is they wake up no more refreshed than they went to sleep. It usually leads, the next step is, from a medical standpoint, can lead to high blood pressure. It can lead to acid reflux. It can lead to all these things in the middle column, anywhere from, and then again, your whole system. So, there are many people who have mild apnea who say, snoring's in my family. Yeah, I can't concentrate quite as well as I used to. You can easily, especially with mild sleep apnea, until it migrates further, you can easily rationalize it's not a big deal. You can still function, but are you functioning at your best? Probably not. So what are the other contributing factors? People in I could probably be in a room with a bunch of people, and just by looking at people, I can usually tell, just looking at their face, looking at their eyes, looking at their skin. I have a very good indication who might have sleep apnea. So there have been studies to show that sleep apnea not only raises the risk of not feeling well and all those things we just mentioned, but it can lead to death. There's this one study, this Washington study, that they showed it could raise this risk of dying, especially with severe sleep apnea, by 46%. There was an interesting study back it started in the 1990s, and it was called the Wisconsin Cohort Study. And the state of Wisconsin, they took many people, I think thousands, 1,500 people, I believe, is the number in the study. And they took people who work for the state and they tested. They didn't treat them, but they tested them for sleep apnea. And then they followed them every 4 years. And they found that after so many years, especially the people who have moderate to severe apnea, I mean, not only were they getting sicker and sicker, many were dying, and the death rate just kept going up and up. So it's not just, I don't feel good. It's not, I'm just snoring. It definitely has a potential to be very serious. So what are things once somebody's diagnosed with sleep apnea? What can you do? Well, lifestyle change, weight loss is good. Keeping exercise, diet, exercise, we've already alluded to that. Then once, if that's not sufficient, then there's there's surgical treatment. So you have choice. When I talk to a patient, I said, hey, you have 4 choices of what to do about this once you're diagnosed. 1, you can do nothing. You can still function, but I could bet that over time it's going to get worse. In really, really severe cases, there's surgical management. And then there's the non-surgical, which includes the CPAP and includes the dental appliance therapy. So what are the lifestyle changes people can do to stay healthy? And these are just things we can do just in general. Just keep your weight down, exercise regularly. Alcohol, a lot of people say, I need a drink before I go to sleep. It helps me sleep. Well, alcohol is a muscle relaxant, so sometimes it makes sleep apnea worse. It actually has a negative effect on the amount of deep sleep and the amount of REM sleep you get. It's recommended not to have caffeine within 3 or 4 hours to go to sleep. Avoid sedatives. Just sleep in a dark room. Don't have your computer and your smartphone in the bedroom with you. And the worst thing most people can do, most people have sleep apnea. The worst position to sleep in is flat on their back. That's when the jaw drops back, the tongue drops back, and that's when most people are most apt to have symptoms of sleep apnea. So what are the surgical treatments? Anywhere from a tracheostomy. There's a surgery called the most successful surgery is the uvulopalatal pharyngeoplasty. Well, it's basically all that is I call it a roto-rooter surgery. They remove all the tissue in the back of the throat. Does it work? It can. They're doing a lot less than that. But again, I made a mistake. The most successful surgery is maxillary mandibular advancement surgery. It's a surgery where they actually break the upper and lower jaw, Le Fort 1 and 2 surgery, and they bring your whole facial structure forward, and they wire your jaw closed. It works, but I mean, again, that's kind of reserved for really severe cases. The newest surgery on the block, and you might see commercials on TV or radio about it, is called Inspire. Now, Inspire, they make this sound like it's a very simple procedure. Well, it is and it isn't. It's a procedure. It's really what we call a hypoglossal nerve stimulator. It's like getting a little pacemaker under your skin and under your shoulder, and then they wire the piece under that, and they wire it down through under your skin, down through your ribs, up to the neck, and they connect it. They put a wire that goes right to the hypoglossal nerve under the tongue. Before you go to bed, you turn this little remote control on, and all of a sudden it sends a steady stream of impulses right to the tongue to keep the tongue forward so it doesn't collapse in the back of the throat. They're getting some very good reviews on it, but again, if I had a choice, that would be the last thing I'd want to do. I would want to do all the non-surgical approaches before going to that. But it is becoming a very popular one, and now a medical insurance is starting to cover it, so it's becoming more popular. But it's kind of misleading when they show the statistics of the studies with Inspire, because they're choosing a very select people. They're picking people with mild to moderate apnea that would be successful in any treatment, and they're saying, look at what the Inspire is doing. So it's somewhat misleading, but it could work. I'm not saying it's not. And then we have the non-surgical, and this is where most of my presentation is going to be talking about. It's the comparison of CPAP and oral appliance therapy. CPAP is still considered the gold standard treatment. Over 90% of sleep doctors, when somebody's diagnosed with sleep apnea, what are they going to do? They're going to give them a CPAP. It's a machine, if you don't know what it is, that goes over the nose and over the mouth and it blows air down your throat. It's basically like taking a bellow down a fireplace, and it just blows air down your throat, and it prevents the collapsing of the tissue in your throat. It works. However, there's a lot of problems with it. There's just the claustrophobic. Statistically, about 50% of the people who get a CPAP just can't tolerate it. So just because it works, I never try to talk anybody out of it. Some people love their CPAP machines, and it works. And again, if somebody can tolerate it and work it, bless them, use it. But then I have a lot of patients who are successful with the CPAP, but they love to travel, and they don't want to, or they like to go camping, and they can't take a CPAP with them. They don't want to take an extended battery. So most of those patients that try the oral appliance therapy, which we'll get into in a minute, most of those patients kind of wean themselves off the CPAP entirely, and they go right to the oral appliance. But CPAP is considered the gold standard. Then there's oral appliance therapy, and that's what, as dentists, that the main topic that I wanted to discuss today. Oral appliance are utilized in the mouth during sleep to prevent the tissues and the tongue from collapsing. I always, when I talk to patients, I say it's the same system. Let's say somebody's unconscious and they're administering CPR to resuscitate somebody. What's the first thing they teach you in CPR? If somebody's unconscious, pull the neck out and the chin forward. Why?
The airway.
To open the airway. It's all about opening the airway. So we can make a custom dental mouthpiece that will open the airway and keep your jaw from the airway from collapsing. It's a simple concept, but not that simple. And we're going to go into why it's not that simple in just a few minutes. There are, and in fact, you're going to see in a few minutes, there are over 100 appliances, dental appliances, that are approved by the FDA that are approved for snoring or sleep apnea. I'd be the first to tell you a very high percentage of those appliances can either not work or they'll cause other side effects. And that's why dental appliance therapy gets a bad name, because a lot of physicians think that it will cause people, everybody get TMJ problems and jaw problems and teeth to shift, but it doesn't have to be that way. And that's what I'm going to kind of show you tonight. Another reason that dental appliances became more popular, even in the last couple of years, is because when people use a CPAP, there's a release of aerosol in the air. And during the heavy pandemic of COVID, it would spread it to people in the house. So there was a big dramatic referral to dentists for oral appliance therapy when COVID hit. Plus, a year and a half ago, there was a recall on some of the CPAP units. So they were shown that there's some release of cancer, potential cancer release in some of the CPAP units. So it's really been a big boom for dental appliance therapy. So how do oral appliances work, and how do we get there? Well, as I just said, by guiding the jaw we can make a custom dental a mouthpiece that will reposition the mandible, bring everything slightly forward, and stabilize it so that airway does not collapse. These are at least from a standpoint of how it works, it stabilizes the mandible and it increases the baseline of the genioglossus muscle. So these are two examples of what happens. On the left slide, the normal airway is the key to good sleeping, where you can breathe through your nose, breathe through your mouth, and the air goes down in your airway, and it's totally open, no snoring, no apnea. And then what happens when you and this is what normal sleeping should be, but if that passage gets too narrow, as I showed in an earlier slide, it could cause the snoring. The tissue gets smaller, it vibrates against each other. So when you have the appliance, it guides the lower jaw forward, and when the jaw's forward, the tongue comes with it, so it creates more space so somebody can't snore, and it opens the airway so the apnea goes away. So what is dentistry's role? What can we do as dentists? Well, first of all, as I've said, obstructive sleep apnea can be a life-threatening disorder. As dentists, we are not legally, we cannot diagnose sleep apnea, but we can work with the medical world, and we can be, if this is a dental solution to a medical problem. So this is covered by because it's a dental treatment, but it's covered under medical insurance. So it's a whole different way of treating people, and we'll get into the medical insurance versus dental insurance in just a few minutes. So what can dentists do? We can screen, we can refer. As dentists, we can see the airway. I mean, we're trained to do oral cancer checks, to check the tissue. How often do you check the airway space? A lot of dental schools are now teaching, hey, what are the things we want to look for? We want to look for an inflamed tongue. We want to look for a long uvula. We want to look for what's called a Malampati score of 3 or 4. And we're able to provide and monitor oral appliance therapy when necessary. And then we can treat the patients, we can refer them back to the sleep physician, and then we can work with the doctor, with physicians and sleep physicians. So, appliances. There are over 100 appliances that are approved by the FDA for snoring or sleep apnea, and many of them are approved for apnea. But again, some of them won't work at all. So what we found, and what I found, is some of the early appliances used to thrust the patient's jaw as far as it could go, and it would work. But then people developed TMJ issues. People would develop teeth shifting. People would develop bite changes. So the last thing we want to do is solve one problem and create a new one. So the biggest change in the development of these products, and the only ones I use, and the only ones that's really recommended from the American Academy of Dental Sleep Medicine, are custom-made adjustable appliances. So we don't thrust the jaw way out. We slowly guide the mandible forward little by little until we find a patient's their sweet spot. So these are just some examples of some of the appliances. There's so many out there. And again, it's not which appliance, it's which appliance will work with the patient, will address each individual patient's needs and be best for that. My job is to pick the right appliance for the right person, depending on the number of teeth somebody has, the size of their jaw, the size of their tongue. Some of it's dictated by their medical insurance. Certain medical insurance covers certain appliances and certain cover different ones. So it's not which appliance, it's which appliance you pick that you can set at the right position. And if there's certain appliances that are better. If somebody is a lateral bruxer, there's certain appliances that are better than others. If somebody, has limited opening, there's certain appliances that are better. So it's, again, not which appliance is the only appliance. It's which appliance is best for that individual. And this is just a list of the different types of appliances. There's anything from tongue retaining devices to one that push the jaw out. There's ones that pull the jaw out. There's one that have these locking arms. So again, I could talk about each one of these individually, but I just want you to know that there are a lot of appliances out there, and you have to be careful who you listen to when you want to make an appliance. And then the American Academy of Sleep Medicine, not the American Academy of Dental Sleep Medicine, but the American Academy of Sleep Medicine came out in 2015 saying, hey, yeah, oral appliance therapy can be an effective treatment, but make sure it's provided by what they call a qualified dentist, somebody who has some training. And that's what they're looking for, that there should be a standard of care, that there's a whole set of protocol to follow if you're going to treat patients with oral appliance therapy, anywhere from making sure they have a diagnosis, working with the sleep physician, making the appliance, titrating the appliance until it's working well for that patient, sending the patient back for a follow-up sleep test to verify that it's working well, and then on a regular basis still monitor that patient. So it's a different system than we're used to in medicine, in dentistry. So let's compare the treatment and the effectiveness of oral appliance therapy versus CPAP. CPAP, again, is considered the gold standard. It works. It improves snoring. It improves the apnea index. It improves oxygen saturation. It improves your sleep pattern. But the comfort and the compliance, the effectiveness is there, but the compliance is not. And again, statistically, about 50% of the people who get a CPAP just have a difficult time. And again, I can't understand, but the medical world considers it successful if somebody uses a CPAP 4 hours, 5 days a week. Now, 4 hours is not enough sleep for anybody. But they needed something to base their success on. So I don't know why they picked 4 hours, 5 days a week to consider it successful. And when somebody gets a CPAP now, their insurance will only cover it if they can prove compliance with the CPAP. So oral appliance therapy, very few people can't get used to wearing a bite splint. And this is a modified bite splint, which you saw some of those. It's just there's two pieces instead of one. It guides the jaw forward, but it can do most of the same things. As far as the effectiveness of the treatment, they're pretty equal in most, especially in cases of mild to moderate severe sleep apnea. The more severe the apnea, the more I would pick a CPAP in lieu of that. If a patient comes in and they do weigh 300 pounds, I don't care how far you move the mandible forward on somebody who is morbidly obese. It doesn't matter because it could collapse from the side. So the oral appliance therapy is not for everybody. The CPAP is not for everybody. So again, it's the medical and dental world working together and finding what's the best solution for each individual. Again, effectiveness versus compliance. The CPAP is really effective, but poorly compliant. The dental appliance is very compliant and pretty effective. If you like Larry David would say, it's pretty effective.
Good. Sorry.
But again, in the right case, in the right cases, and when a patient comes in and they can't handle a CPAP, and they know they have sleep apnea, and they don't want to have surgery, okay, let's just say that I can improve their apnea by 50%, even though it's not 100 totally successful. Are you helping that patient? Certainly you are. So, what are the things that are recommended by the American Academy of Dental Sleep Medicine and Dental Sleep Medicine? We need to do an oral exam. I mean, there's certain things we look for. We look for certain traits that a patient has I'll show you in just a second. We have to make sure it fits properly. It's not like giving somebody a bite splint and say, see you later. We have to make sure it fits properly. We have to make sure the patient can wear it. We have to make sure we can titrate it until we at least subjectively find that it's working for a patient. And then we have to follow up and give a sleep test to verify the effectiveness of it. And that's also how you get sleep doctors, how you get people to refer to you as a dentist, by showing the success, by showing that you're doing it the right way. So, diagnosis has to be a medical evaluation. I've had patients come to see me and say, look, doc, I don't want to go through that whole sleep test. I snore. Can you just make me an appliance for this? And I won't do it. I will not treat a patient unless they've had a medical evaluation, unless they've had a sleep test. Because you could actually, if you make a sleep appliance and you don't know what they have, and you could actually turn somebody who can stop the snoring, but they could become a silent apneic, where they still could be having collapsing of the airway, and you don't know it, and that person goes down and they start driving the car and they collapse, and you're liable. If you're treating somebody without a diagnosis, I mean, you would not survive in a court of law too well. So it's so incumbent that we get a proper diagnosis, that we work with the medical world, that they get the proper diagnosis. What are the indications? Indications are primary snoring, and getting the right patients, people who are intolerant to CPAP, the right people who just can't handle surgery. That's it. So there's so many people we can treat. So what are things we look for? What are some of the things we want to make sure? If somebody has a little TMJ clicking, that doesn't necessitate that patient is not a good candidate. They still could be very good candidates for dental appliance therapy. In fact, sometimes the oral appliance therapy can actually improve TMJ problems. If somebody has some clicking of the jaw by pulling the mandible slightly forward, it opens up the space where the condyle and the go into place, and it can help in many cases. So that's why we don't just jam somebody's jaw forward and expect that to work. It's a process. We check the range of motion of somebody. We just don't jam somebody out. What I do is I check how far the mandible can go naturally on its own, and I usually start somebody at about 50% of where they can of their range of motion, and that's kind of the starting point. And some people, we never have to go more than that. We look at dental relations. We look at people who have overbite and overjet. Somebody who has a retrognathic jaw is probably more suspicious of having sleep apnea. People who you can see wear facets. We can all see people who are bruxers, and those are things we look at too. Again, not everybody who bruxes has sleep apnea, but just about everybody who has sleep apnea does grind their teeth to some extent. We look at perio conditions. If somebody has advanced perio, I'm not putting an appliance in their mouth that will put pressure on the teeth and shift the teeth. That's the last thing I do. So again, we have to know our dental history and our dental condition too. Who are the good candidates for this? And not everybody is a good candidate for oral appliance therapy, but most people are. We look at some of the key things we look at. We look at the size of the tongue. Certain people, if you look at people's tongue and they have this scallop pattern on the side of the tongue, that's usually an indication somebody has a big tongue that's probably closing off the airway. Somebody has a long, soft palate. Somebody has a long uvula. Tonsils can be blocking the airway. So there's all these oral pharyngeal tissues which are blocking the airway many times, and that's what we look for before we ever start. I try to explain to patients why Mrs. Jones, why do you have this? And I said, this is what your tongue looks like. This is what we would like it to look like. You have all the common characteristics that each one of these things by themselves, a big tongue or a scalloped tongue or a long uvula by itself, no big deal. But you have the perfect storm where you have many of these same characteristics, which can lead to the same condition. So, obstructive sleep apnea, it's associated with decreased quality of life, neurocognitive, cardiovascular, metabolic consequence, and increased mortality risks. It's a health issue. I mean, again, it's something that it's often misdiagnosed and untreated, and it's imperative. This last line, it's imperative that dentists assume more of a role. The American Dental Association is now saying that as dentists, we should take the role to it. If nothing else, we should be screening our patients. Even if you have no desire to treat it, you can still screen and then refer them to their physician that will then send them for a sleep test. So I think that is so important. So why practice dental sleep medicine? Well, we're the #1 portal. I mean, how many people we develop relationship? What I love mostly when I did general dentistry for 35 years, I love the relationships I had with my patient. I loved being able to become friends and knowing the patients and their families. And people begin to trust you as your dentist. And if you could help somebody's health in any which way, how satisfying is that? We see more patients than just about every other profession for medical treatment of patients. And we have a clear view of that airway. So I love this slide that I used to tell people I love helping people save their teeth. Now I say I love helping save their lives and their relationships. I mean, I can't tell you how many times I'll be out with my wife. We'll be out somewhere and I'll see a patient that I've treated, and the spouse of the patient comes up to my wife and says, your husband has saved our relationship. We're now in the bedroom together. In fact, I have a funny story. I had a patient come in and they said, I know I need this. I have these problems, but I don't want to tell my wife I'm getting treatment. I'm saying, why would you not want to tell your wife you're having this treatment? He says, I love having my own bedroom, and I don't want to tell her I'm doing this because then I won't have my own room anymore. So just a sideline. So sleep apnea, it's not just giving somebody appliance. It's an interdisciplinary approach to medicine. We're working with cardiologists. We're working with psychologists. We're working with primary care physician. It's a sleep medicine, and again, dentistry has a definite line of treatment that we can help so many people with. And even in the last 10 to 15 years, the dental appliance therapy, there have been many, many studies where up till 10 years ago, a lot of sleep physicians, it was CPAP or nothing, and they didn't want to refer. That the only people they refer for dental treatment are people who had snoring with no sleep apnea, because they thought that it would cause all these problems that it doesn't have to. There's no reason why somebody should get TMJ problem from wearing a dental appliance. There's no reason why people's teeth should lift. If you do it the right way, not only do I make every patient an appliance, but every patient also gets a secondary piece, what we call a morning repositioner. When somebody wears a dental appliance for sleep apnea and their mandible is positioned forward all night, when they wake up in the morning, it takes a few minutes for the mandible to settle back. What we do, we take an occlusal relationship, we make a little splint. When somebody wears their dental appliance at night for sleep, they get up in the morning, they put their secondary piece in, and it makes sure everything goes right back to place. So basically, we're making a retainer for the retainer. So I recommend a couple books that I have found to be just really, really important. And one of the new things that has come out in the last few years is the importance of nasal breathing versus mouth breathing. And this book called Breath by James Nestor has been instrumental. This book is on the New York Times bestseller list, and this guy was a scientific journalist that would study people. First of all, he studied people who were free divers, who can hold their breath for 5-10 minutes at a time, and then he extrapolated and he started to work with people who were mouth breathers versus nose breathers, and they would block somebody's nasal airway totally, and just about all the people would develop classic symptoms of sleep apnea. Then when they reversed it and they get them to breathe just out of their nose, all these symptoms went away. So it's really instrumental in understanding the importance of breathing. I'm just reading a book now called The Breathing Cure, which it's a 400-page book to teach you how to breathe better through your nose, which is so much healthier. When we breathe through our nose, there's a release of what's called, in our nasal sinuses, of what's called nitric oxide, which is really is a vasodilator. It's plus breathing through your nose, you're filtering the air, you're moistening it. It's so much healthier to breathe out of your nose than out of your mouth. And then there's a book, Why We Sleep, just if you want to know the importance of sleep. And again, I used to be a person, probably for 30 years, I probably got 5 to 6 hours sleep thinking that's all I needed. After knowing what I know now, if I don't get at least 7.5 hours sleep now a night, I feel I cheated myself. So we need not just the quantity of sleep, but we need the quality and the quantity of sleep. If somebody has true sleep apnea, I don't care if they're in bed 10 hours. It doesn't matter, because all those stages of sleep get interrupted. So you need the quality of sleep just as well. And I'd say, again, from what I said earlier, I think we're in a sleep-deprived society today. And I think slowly but surely, I think we're all understanding the importance of sleep. So let's go on. So I think that is about most of my presentation. I don't know if there are any questions out there. I can elaborate on quite a few things, so we'll take it from there.
Yes, we will. And yes, I have quite a bit to share with you, Earl. But the first thing I want to share is that I just counted in my introduction, I made 8 promises on your behalf, and you ticked off each and every one of them, and you did it in just over an hour. So I want to congratulate and thank you for that. I'm sure our attendees are equally appreciative. And before we move on to the questions, I do want to share with the attendees that you shared with me that you're looking to expand your practice and you're inviting interested parties to reach out to you. Why don't you take a moment to let our attendees know what you're looking for?
Yeah, so when I started getting involved with this, I think I told you I had a general dental practice for 35 years. I sold my practice to another dentist, and then I rented space from the office I owned for the year to do my sleep medicine. And the office that I built up, I rented one operatory in the practice, thinking that's all I'm going to need. I'll do a few cases here or there. Well, it's gotten busier and busier, and now we're at a point where I can't keep up with the amount, and I need more room. So I just, again, people might say I'm a little crazy, but I'm 69 years old, and I just signed a new 7-year lease on a new space that I'm building out, a whole new office that I could dedicate my entire practice. I'll have 3 operatories to work with, and once I do that, I would love to find to mentor another dentist who I could work with and who could take over, and I can teach, because it's not just making an appliance. It's, the medical world is very different than the dental world, and how we treat patients and how we bill out, how we charge patients, and I've learned anywhere from how to work with medical insurance to which appliance I think works best in which situation. So I think I have enough experience. I've been doing this for over 12 years now, and I've kind of built up a niche. I now have at least 5 or 6 sleep physicians that refer to me regularly, because they know that I do it the quote unquote the right way. There are many dentists who take one weekend course and then they go to their doctor, these sleep doctors, and they say, here, send me patients. Well, that's not a way to do it. There's many ways to do that, and I think I have the systems intact now that I want to elaborate, and now I'll be able to do much more than I have been doing. I've been linearly scheduling patients, and it's getting on my. I have one key member of my staff who has been instrumental. We all need good staff members, right? Well, I have one staff member who's been with me over 30 years, and she's worked every position in my general dental practice, and now she has basically took the bull by the horn, and she is running my dental sleep medicine practice. She knows everything about how to get patients get them diagnosed, get them into our schedule, get the patients to follow up. So we all need key employees, and I think I could help others do the same, build up the same things.
I know you can. I wouldn't let Earl's age discourage or worry anybody. Why don't you share how many thousand miles you bike a year on average?
First of all, I love what I'm doing. I not only do I practice 3 days a week, which I love to do, and I also teach one day at University of Michigan Dental School, which I didn't know. I met the dean of the dental school at a conference, and I said, is there anything in the curriculum? This was 5 years ago. And she said, well, we want to get into it more. How about if you come in and become an adjunct clinical professor? You can help develop this. So I've learned in the university world, there's a lot of bureaucracy. And to get something into the system, it's taken a lot longer than they said. But I really, really enjoy working with students. So and then also I'm ultra health lifestyle where I exercise fanatically. I run. In fact, I run one marathon every 10 years, and I'm turning 70 this year. So I plan on running a marathon this year. I bike thousands of miles every summer. So I'm very active. I love what I do. As long as I stay healthy, I'm going to keep doing all this stuff, and it's work for me.
And Earl, let me ask you something. Do you mind if I put your website address into the chat field so people can see that and learn a little bit more about you that way?
Absolutely.
I'll do that right now. There's some really great testimonials from some students there, and I can speak to Earl's success because essentially he fired us. He didn't need us anymore. So that was a good thing. We like to work ourselves out of a job. So I think that was a great step, and anybody that chooses to work with you will have as much fun, I'm sure, as we've had working for you.
It's so fulfilling to see somebody who comes in who has all these daytime fatigue, just can't function, and all of a sudden they're like a different person, and it changes people's lives. Does it work for everybody? No, but what does? So again, I always tell patients I don't make any. I under promise and over deliver. I think, Danny, that's kind of your philosophy and what you do.
My motto too. Yes, sir.
And it's what I've always told patients. And again, I tell people say, can you guarantee me this will work? I tell them I can guarantee you I'll do everything in my power to get it to work as well as it could. And most people, there's certain people who have a higher predictability of success. Some of you mild apnea with who are not obese. Hey, are usually no-brainers. But then there are other people. I've treated people who have really severe apnea that couldn't handle anything else, and we've gotten great success. Does it work that way with everybody? I can't say it does. But I don't make false promises. I don't guarantee that it's going to work. Hey, great. I said we'll do what we can. And if you can follow my advice, I think you have a high rate of success. So that's how I handle my patients.
That's great. All right, let's move into the questions because we've got 8 of them, and I think we've got time to go through them, depending on your answers. The first is, and some of these questions you've already touched upon, but they were asked before you got to that particular section of your talk. But I think that they warrant maybe a little bit of elaboration. So number one is this covered by medical, dental, insurance, or both?
Okay, so this is a dental solution to a medical problem. This is covered by medical insurance, not dental insurance. The biggest roadblock most dentists get into when they start to do any kind of dental sleep medicine is getting paid. Because when I started to do this, I would bill out to a medical insurance, and most times, more than not, it would be denied. They said, "You're not a physician, you're a dentist. This is a medical treatment." So over time, I learned how to bill out from medical. I use a medical billing service, is like my other employee, and they know how to get. They've taught me, and they've gotten me into medical insurance, where I am now a subscriber in the medical insurance world. I'm in network with most medical insurance, including Medicare, and again, so it's something that takes patience, and you have to know how to do it. You could have, if you had just an employee in your office trying to do the medical billing and doing, we do a insurance pre-authorization for every patient, because I want a patient to know what their costs are before they ever start. And it would take somebody to work all day just to do that. So I've kind of distributed that to this medical billing service, which finds out all the information on that patient. It finds what their deductible, what their copay. We always like to inform before we perform. I always start a patient. I do a free, one good thing came about from COVID is I started to do telemedicine appointments. And all of my first appointment with somebody is a telemedicine conference, but I don't do that appointment until I have a sleep study and until I have them fill out these documentation, so I can talk to them, but I can do it from anywhere. I can do it at home. I can do it from my office. And that first consultation is about 20 minutes long, but and my belief is, I would say about 70–80% of the people who do have that consultation, if they're a good candidate for it, if they don't do it, I consider it my fault, not their fault, that they're not following through. So I have a courtesy consultation, but I'd say 80% of those people who are good candidates usually follow up and do sign up for the treatment.
That's great compliance. I'm going to combine two questions here because they're so similar. How do you decide which appliance to use? And then I guess as a little follow-up, how often does it happen that insurance precludes you from recommending the appliance that is best for the patient? And in that case, what do you do to tell the patient in such situation?
I like to point out, it's not which appliance. It's what appliance is made at the right position for each individual. There are many appliances can do the same. I have 6 appliances for a couple reasons. One, when something new comes on the market, I like to try it because I want to be able to tell a patient how it would feel. For me, any and all of them work just as effectively as long as my mandible is slightly forward. Other people, it needs to be very, very specific. It has to be just because of their certain anatomical characters that will limit it. But there are other reasons. Some, like Medicare, has certain rules of which appliance they will pay for. And if you don't follow those rules, not only can they deny it, but if you do it, then you have to pay them back plus. So the Medicare rule is the appliance has to have a metal hinge. Why it has to have a metal hinge, there's no rhyme or reason why, but you have to follow that rule. So I tell a patient if they don't want that, they would have to pay out of pocket for a different type of appliance. So I've narrowed it down to about 5 appliances that I think work, that I could work with almost anybody, that will not cause TMJ issues, will not cause teeth shifting, will not cause bite changes. So again, it depends, but I show patients what I think would be best for them, and then they have the choice. But
that's kind of where I'm when I'm interested into, Earl, because I've worked with medical professionals. I had one who I forgot what procedure I was asking about, but he said, yeah, we don't recommend that. And I said, well, why? I thought it was the gold tint. He goes, yeah, but our insurance won't cover it, so we don't recommend it. And to me, I'm taken aback by that because we don't want insurance to dictate care. They're not the healthcare
I agree.
experts.
Again, you sound very much like myself, and I know some things you're doing, Dan. But if I need a medical procedure, I'm going to do it. I mean, my health is everything. Without good health, I've seen too many things lately in some of my family members. If you don't have your health, you got nothing. So whatever.
Exactly. So you think you're doing your patient a service. What you're really doing is you're avoiding it's fear of rejection, I think. And you don't want to doctors and other people they don't ever like to put on the salesman's hat, which
I hate when people say I'm only going to do what my insurance covers. What why do
you've abdicated your health to a company who's more interested in cost containment than in healthcare.
Why do we let medical insurance companies tell us what we can't, how to stay healthy? It's crazy that's what the medical world is. The dental world isn't quite like that. We still have some choices, although it's becoming more and more corporate too, and we have a lot less choices. So insurances are trying to get in the dental world too, but not to the extent like some of my medical friend colleagues who are just their hands are tied in what they can do, and this is a perfect example. So again, I tell patients what I think is the best treatment for them. They have choices. If they can either follow that, but again, even if they follow, do what the medical insurance will cover for it, it can work. It still can work. And
right, because it covers a lot. I know Medicare will reimburse.
And again, it's not which appliance; it's where the appliance is set and where if we can adjust it to the right position. It's getting whatever we're doing. It's trying to get that airway open. So what is it going to take to get that airway open? That's what we have to decide.
Got it. All right. Next question. How do you avoid side effects?
I do have a couple go-to appliances, which I really like. Of everything
you got
is equal.
6. Yeah.
There are some that I think are better. There's some new technology on some of these appliances, which I think they keep getting smaller and smaller. They're almost like little Invisalign trays now. And some of these, there's one company specifically that I think makes a great appliance that when everything else is equal, that's what I'm going to recommend.
Okay, how do you avoid side effects from wearing the appliance?
So one of the things I briefly talked about is making this morning repositioner. Again, first of all, you can minimize side effects by slowly titrating the having this adjustable custom-made appliance. Some of the over-the-counter appliances, they could work, but they're so big and bulky. And how does a patient buys this thing over the counter and it says, okay, move your jaw forward. Now, how do you know how far to move it forward? You don't know anything. So what we do is, first of all, I always start at a position that I think the patient is going to be comfortable with, and then slowly adjust it forward until we find where symptomatically they're going to notice a difference. Once they notice a difference, then we do some testing on it to see how effective it is. So it's not just like thrusting a jaw. It's a slow, some people, we set it at one position, we never have to touch it again. Others, we have to keep adjusting it. But I'm very conservative in how I treat some because I want to minimize all those side effects. And by wearing that second piece, that morning repositioner, to me, that's key. Because because some patients who don't wear it and they say, well, my teeth are coming together, but then slowly but surely, all of a sudden they have a posterior open bite, their teeth aren't coming together, teeth start to shift, and then to overcome and back things up and get it back is so much harder than if we ever did prevention to begin with. So I am ultra careful about. I'm as proactive in preventing side effects as I am to get this to work for that patient.
While we're on the subject, I'll move up this next question. Is the morning repositioner also reimbursable?
Is it also reversible?
Reimbursable, I mean, is it covered?
Well, Medical insurances don't cover it, but I will not make the dental appliance without making that. So if a patient said, well, I'm not going to pay for that, I say, well, then I'm not going to make you the first one. So, I think our fee for the morning repositioner, I think it's $150 what we charge.
Right. So it's a small percentage of the main
I will not make the
procedure.
first appliance, the sleep appliance, unless I make the second.
But given the price, I don't imagine you meet with much resistance.
No,
anyway.
If that's the stopping point, then I don't want to person anyway.
Yeah, there's something else going on. All right, what is the best way to get referrals from physicians?
Well, one is to call meet the doctors, but they're so busy, the sleep doctors, your physicians, so you have to get them to believe. You want to separate yourself from the pack. You want to, first of all, refer to them. If you have a patient, if you're screening people and you're sending them to different doctors, they're going to start to know your name. And then once you start to treat people, and then you not only do you refer to them, but then you treat them, and then you send them back to have a follow-up test, and then the sleep doctor sees you're successful, they're going to start referring to you. So it's not, you don't want just them to send to you. You want to send to them. It's kind of you have to have a reciprocal world with the sleep doctors, and it takes time. I mean, I separated myself because I wanted to separate myself, so I became a Diplomate of the American Board of Dental Sleep Medicine. I didn't want to just take one weekend course. I wanted to be trained the right way. So I did that. I showed that separated myself right there, and then I started to refer them. So, and again, it's not overnight. It's not going to happen overnight. It takes time. And I started when I started to develop my practice, I was still doing general dentistry. I picked one day a week. First, I started a half a day a week, where even if I didn't have a patient, I studied, I read something. That was my time for my dental sleep medicine. And then I expanded it. And then I slowly, so I learned that you have to, I found it very difficult to go between a dental sleep medicine patient and let's say a crown preparation in dental dentistry. The whole mindset of treating people on a medical model is very different, and I found it hard to go back. That's why I started by separating just a day a week, a half a day a week, then a full day a week. Then I kept expanding and kind of built it that way. So that to me, some people can do a mindset and they can go back and forth. I find it very difficult to do. So that's kind of how you have to separate yourself from other practitioners. You got to build the trust of the sleep doctor, because they have a lot of dentists. A lot of dentists take one weekend course and then they go to the doctor, and then they treat that patient, and then they get back and they say this appliance didn't work because they didn't titrate it right. They didn't know how to titrate. So again, you have to know what you're doing when you're working with the doctors. You show them that you're successful, they're going to send to you.
Yeah. Well, you make two excellent points, but you also concurrently shared sort of the process that you underwent to making the transition from a general dentist to a dental sleep medicine practitioner, which is very, I think, enlightening and informative. I'm glad you did it. And just to underscore, the 2 points are, number one, you want to differentiate yourself, because there's a lot of dentists out there who purport to offer this, and as I think anyone who attended your course today understands, that there's quite a bit more than meets the eye to being a successful dental sleep medicine professional. And then the other point that I think is really important to underscore is that the smoothest referral path is one that is two-way. And if you want to grease that skid or lubricate that path, then begin by referring to them. And when you do in your communications, get in the habit of referring to the patient as our patient. That you're sort of on a level playing field. You're both working towards the same goal, which is the betterment, the health, the longevity of the patient, and that this is why you're so passionate about what you do.
And I also, Annie, every time I see a patient, I send a fax. A note to the sleep doctor saying, "Hey, we just saw the patient. We're in the midst of this treatment." I keep them informed. I keep my name in front of them as much as I can.
Mm-hmm. And yes, Earl did say fax, because that's still how the physicians prefer to be communicated with.
That's how they like to communicate. They don't want you to email. They don't want you to call them. They want you to fax any information on a patient. That's how they communicate.
So you run the race at their pace and in their arena, I guess, their channel. All right. What are the best classes to take? This is all related. What are the best classes to take to learn more about obstructive sleep apnea and oral appliance therapy?
I think as a dentist, you're going to find, I'm sure if there are any dentists listening, you're bombarded with these classes about dental sleep medicine. There's a lot of classes out there that are supported, that are put on by product-oriented companies that sell their products that will help do this. I think the most important way to get trained is to do it through the American Academy of Dental Sleep Medicine. The American Academy of Dental Sleep Medicine they want it to be education-based, not product-based, and they have programs that will train you. They have programs that will give you a mastery program so that you could become you can become a diplomate. But it's kind of a step-by-step procedure. And again, they're now having a couple universities around the country that are going to be their main teaching sites. I know there's one at Tufts in Boston. I think there's one I know there's one in California. And University of Michigan is now just been accepted to be a future training site for this mastery program in training dentists to become. So it's not just taking one weekend course. In order to become a diplomate, there's certain requirements you have to do. You have to have so many cases. You have to spend time with sleep in the sleep lab, learning about what the sleep physicians do. Once you present a certain amount of cases and you show some expertise, then that allows you to take an examination so that you can separate yourself, so that you can become a diplomate in the academy. So again, there are a lot of organizations. I'm not going to say that some of these product companies who put on continuing education are bad, because they are good. They got some great people teaching that. But they're a little biased. There's some biases in there, and I try to avoid the biases. I think it's good if you just want to get a general education. It's good to get as many areas of feedback as you can. An again, in my opinion, I think the bottom line, once you have enough background, is then go through an organization that will support you. And just like organized dentistry, we need an organization that's going to support what we're doing, and that's what the American Academy of Dental Sleep Medicine does.
Very good, because you also anticipated my next and final question, which was, what does becoming accredited by the ADSM entail? Maybe you could just wrap it up for us tidily in terms of how much time it took you, or how many classes, or you sort of gave us an overview.
A number of
already.
Years ago, they didn't have these classes to teach the mastery program. They just gave you had to do it all on your own. You had to study, you had to read a certain amount of studies, you had to do all the research on your own, that in order to qualify to take the test. And they realized, the organization realized that not many dentists are going to do that. So there's a very few diplomates. So they said, we need a system that's going to make it easier for people to follow. So now, as of I think even the last 3-4 years, they now have set up this whole mastery program that you can get educated through the academy. There are different organizations. There's the ASBA, which is a breathing academy. So there's different levels. But my belief is, I think just like we need organized dentistry, we need an organized organization that's going to help keep dental sleep medicine where it's not becoming just a haphazard, do what you want to do, where there is a definite protocol.
Standards, yeah.
And I think that's important. To me, I have a very definite protocol I follow with every patient.
Yep. I know you do, and you must. So that's
it's
important.
Not by accident that you know how to do this, and you want to do it the right way. I mean, I love doing dentistry the right way. Right. I love treating people the right way, and I think I've come up with a system that I found that I could do this with. But it takes time, and you have to be
Right.
It's not, a lot of these companies, take this course and you'll make $1 million. This is going to be the biggest profit margin you'll ever see. Well, I don't, I think that it's not a pile of bull for most of the time. You have to do it for the right reasons. If you're doing it because you want to help people, that's great. If you're doing it just
the money will follow. Yep.
Yeah, I mean, you have to. As I taught my daughters who are 27, 29, you got to find something you love to do, and you'll figure out a way to make it work financially. And if you love what you do and you do it the right way, it works.
Right. And any involved procedure that has consequences, you need to be consistent. Just like if you're going to fly an airplane, everybody goes through the flight checklist. Every single time, the same thing. And that's how you ensure excellence and consistency. All right. Well, let me just remind you that in a few days you will receive an email detailing how to apply to receive your 1 1/2 hours of CE. And I now want to invite you to mark your calendars for Thursday, March 23rd, just 4 weeks from today, when my very special guest will be Mr. Ken Runkle, president of the Paragon program, whose presentation is entitled Profitability Through Growth, Make Change into Dollars. Ken Runkle, America's profitability expert, is a much sought-after speaker and consultant for dental professionals throughout America. He consistently entertains and motivates audiences to higher levels of achievement and practice profitability. As the founder and president of Paragon Management Associates, Inc. and the Paragon Program, Ken has counseled and presented to dental professionals throughout the country on the subjects of personal and practice development. With more than 35 years of consulting experience to over 1,000 dental practices, Ken delivers strategic and common sense solutions upon which to build an efficient and consistently growing practice. Upon completion of this session, attendees will be able to define business profitability, business growth and change, implement change, growth, and profitability, and understand how to monitor and measure change for growth. That all happens on March 23rd, Thursday, so be sure to save the date and watch your inbox to register. Until then, this is Danny Bogrow, thanking you for your commitment to practice perfection and wishing you all a very good night, and thanks again to you, Earl.
Okay, thanks for having me. Take care. And if anybody wants to reach me, you see my cell number and my email. Feel free to contact me.
Thank you, Earl. And we'll make sure everyone gets the recording of the presentation, and it includes your contact information. So thank you all again, and a good night.
Good night now.